Welcome to The Pursuit of Health, the podcast on health policy for a free and modern society. Well, welcome everyone to another episode of The Pursuit of Health. I'm your host, Rainier Schur. Joining me back on the show is Jared Rhodes and Colleen Smith. Welcome back.
Thanks for having us.
So, what I thought we would do today, instead of discussing another one of our articles or a bill that we've testified on, is to delve into a wider topic that is pertinent to the discussion of healthcare in America today. And that's the topic of how should healthcare be paid for? I think a good question to start for our audience is to explain, well, how is healthcare mostly being paid for in America, and why might there be problems with how that's being done?
I mean, at the moment, health is primarily paid for by health insurance. Health insurance either comes through your employer, you can purchase it yourself on the marketplace plans, or it's provided by the government through Medicare and Medicaid. There's some overlap in all of this. So there's government that gives tax breaks to employers for providing health insurance. There are government subsidization of many of the marketplace plans that people purchase. And in a few states, there are health insurance plans that are offered outside of the marketplace that was set up after the institution of the Affordable Care Act, but a majority of states don't allow that at the moment. And then a very small percentage, something like I think less than 10% of people pay cash for their health care.
Well, suffice it to say that people are definitely not happy with how the healthcare is being paid for. On the patient side, they're upset with high premiums and high deductibles and surprise billing. On the provider side, it's prior authorization and bureaucracy. But when it comes to fixing this issue, there seem to be two kind of solutions that are being offered. One is the kind of dominant solution, which we're all familiar with, which is that we have to fix health insurance somehow, that the way that it's paying for things. We have to add new regulations to prevent prior authorization. We need to go after the profit motive from health insurers, but still essentially agreeing that, yeah, health insurance should be the main way that most of healthcare is being paid for. But another solution that's kind of coming up these days in different areas is alternative ways for paying for healthcare. And you see that with direct primary care and with these cost plus pharmacy ideas like those pioneered by Mark Cuban. And what's interesting is that while the latter kind of solution of shopping for healthcare is gaining traction, it also faces pushback of like, well, is that even possible to shop for healthcare? And is it morally desirable? And those are the main questions that we are going to tackle today. But before we get into that, a good question to ask first is, why does health insurance pay for most of our healthcare? How do we get into that situation to begin with? And what's the positive case for insurance paying for most of our healthcare?
I think there are a few different reasons. One that I often come back to is the way that the tax incentives work in the US. Employer-sponsored health insurance, it can be purchased on a tax-exempt basis. So you end up getting more for your dollar, so to speak, if you purchase health insurance through your employer. That probably sounds like a good thing on the surface, but you have to recognize that it leads to some distortions though too, which is that now you're kind of lumped in with the people that you work with, and why should that be a natural kind of way that we're doing this? Like you don't get you probably don't buy your car insurance from all the same places that your coworkers do, right? I mean, like, why would that be the way to do it? So what we have here in the U.S. is it's like a group insurance based system where you're buying group policies, often through an employer, because you get that extra kind of tax boost from it. That leads to a few things. It leads to some economists look at this and say, well, you end up buying more insurance than you need because it's artificially cheaper, and then you have this incentive of well, you might as well buy as much as you can, because if you don't buy that and you just take the dollar in terms of wages, well then you buy other things with that dollar from your wages, then you're paying a tax on that income. And so it does lead to people buying a lot of insurance, and then once they buy it, they feel like, well, I paid so much for it, I might as well use it, right? And then that that comes up in a lot of even kind of clinical situations where you're trying to decide whether to, should I take this, to get this test done or that procedure done, and it can feel like, well, I've already paid so much. I've already paid 10, 15, 20 grand for me and my family to be on this plan for this annual cycle. I should probably get my money's worth, right? I should say yes to as much as possible. And so that's at a very high level, that's kind of the dynamic that I think, not the only one out there, but that's one that I think that is pretty influential in the way that in causing the U.S. system to work the way it does.
I also think insurance has begun to kind of fill in as the decision maker in helping patients and doctors decide what's appropriate to do or not. People bring this up in terms of this information asymmetry argument. You need something between doctors and your money because there's too much information asymmetry. The doctors know too much and the patients don't know enough. And so somebody needs to be there, whether it's the government or your health insurance company, to just kind of make sure that everything is meeting the whiff test or whatever, right? Like patients just can't figure it out on their own. And if doctors are left to their own devices, they'll just go crazy and order all the tests. I think there are a lot of reasons why that's in most instances in healthcare, that's really not the case. Most of healthcare is not an emergency. Most of healthcare is something that you have time to think about and doctors have time to think about. And especially today, I think most people expect some explanation from their doctor, whether insurance will pay for it or not, about why they might want to do a certain test or procedure. I struggle with this information asymmetry argument personally because I think that it really treats doctors and patients, it, kind of it puts them in a bad light. I think patients are smart enough to make decisions with the help of their doctor, and doctors are benevolent enough to, in general, to try to do the best thing for their patients, taking into account the context of their patients' lives, which health insurance just doesn't do. But I think that is why, like, one of the roles that health insurance has begun to take is to be that arbitrator.
And we're definitely going to tackle the asymmetry of information arguments further on as well. But before doing that, I think it is important to point out to our audience that this idea that insurance pays for most of our healthcare, which we now just take for granted, that wasn't always the case, right? And I think this is really explained very well in Christy Ford Chapin's book, Insuring America's Health, where she explains that before insurance started playing this role of paying for most of healthcare, there were other models for paying for healthcare, whether it's the company physician or these group practice models that we've talked about before, where you pay a subscription for a multi specialty service. The idea that insurance would pay for everything, no one liked that idea, but it eventually became the dominant way most of healthcare was being paid for because a lot of those alternative ways of paying for healthcare were being squashed by the American Medical Association. And why was that? Well, they were worried that these other models would commercialize healthcare too much, right? And so it was explicitly a concern that, well, we don't want patients to shop for healthcare, and we don't want doctors to think too much about the cost and profit. And of course, they have to be well compensated, but we don't want to think of doctors as businessmen. And so, because they went after those other models, really the only model left in town was insurance paying for it. And importantly, insurance paying for most of healthcare also insulates both doctors and patients from being shoppers and sellers. It's true that the tax incentive allowed that model to survive at all, but there's definitely like a kind of moral core to it that also explains why it was being proposed to begin with. And so now that that's a bit clearer, should health insurance pay for most of healthcare? I think that's the next question to get to. Is it actually, leaving aside the moral question, is it a practical way to pay for most of healthcare?
I think we would say no, not in its current form. Of course, we're not like against the idea of insurance. I mean, insurance in many ways is like a brilliant financial invention. Somebody came up with a way of pooling funds and pooling risk, and if you can design it in a way that it really is working like insurance, there's ways that certainly that you can make kind of rational use of it and everything. But we're not really, given the policy uh, you know, context that we're in, we're not really working in that world. I mean, I think ideally you would not use insurance for something like, routine small dollar care. There's probably not much of a reason to be paying for small things that are, just even just a couple of $100s or less. So you should be probably paying for that out of pocket or out of a health savings account, right? This is where some of these other ideas can be helpful. And modes of financing healthcare. And part of the reason for that, there's a number of reasons, but one of them is just the administrative complexity, and you're now involving paperwork and checking, and somebody has to be employed at each place to have this transaction of here's the claim and here's what was provided and here's all the documentation and does it all check out and all of that. You're sending things in the mail a lot of times. There's just all of that to handle like maybe an annual primary care visit or something like that is not terribly efficient. Insurance for a medium to large size surgery or procedure, I mean, that's where you want this to be used. The kind of uh, the thing that you couldn't easily afford out of pocket or savings or a health savings account, things that are, and then there's other just sort of like regular principles of insurance too. Things like, in general, for insurance to work well, it shouldn't be something that is predictable. It shouldn't be something that you have direct control over. It should be something that, again, is kind of on the expensive side, not something that's small or trivial cost wise. There's these things that make insurance make sense or not, and those are some of the kind of like principles. There's a few more kind of conditions that you usually think of when you think of is insurance the right way to fund something or not.
What also surprised me reading about the history of insurance taking on this larger role is that we tend to think that, oh, like, well, then like the doctors just pad their bills and right and like start charging unnecessary services, which did happen, but apparently that wasn't the main concern from insurers. The main concern from insurers was the incremental increase of the fee for services over time, right? And essentially what the uh, insurance paying for most of healthcare did was kill the competition over prices, right? So, which is was much more of a driving force of the increases in premiums than any kind of bill padding.
I think it also killed more than just competition over prices. It killed competition over quality, competition over innovation. And speaking to insurance executives, at first, they didn't actually care about rising prices. As prices went up, insurance companies just increased premiums. And it only was when employers who were paying the most for healthcare, and now to some degree, Center for Medicaid Services, who is like setting price limits, have come in and said, like, no, no, this is too much. You need to figure out some way to bring prices down because we can't pay these premiums. That's really when insurers started to be motivated to do anything about prices. And ultimately, what's kind of happened is this ironic thing where insurance pays for all of the common stuff. And then when you really need them to pay for expensive things, they pull out prior authorizations and deny the care. So we kind of have like the opposite of what we wanted to begin with. And we've lost this consumer choice check on prices and value that we would have had we not switched to insurance paying for everything.
And I think another component of that is also the fact that the insurers, they actually never really wanted to manage healthcare, right? They just wanted to do the work of balancing risks and premiums and profits. But at the end of the day, they were responsible for controlling costs, and that's why there's such an emphasis on coding and billing and insurance and like all this paperwork as a way to make sure that this running tap doesn't overflow the system with costs. right?
Yeah.
Which leads to all sorts of problems because it means that doctors now have to focus on coding rather than really what's most important to their patient, which sometimes there is no code for, right? And so it like literally limits the thinking of doctors themselves. And so like I don't blame them for wanting to leave the insurance-based system because if they don't take insurance, they don't have to force their thinking through some coding matrix and can actually get back to patient care. And so I think that's probably where we should be going next. If not insurance, how should most of healthcare be paid for? What are some of the alternative ways that people are thinking of?
I sort of touched on some of these a minute ago, just when I said like in a world where insurance is maybe properly scoped and you really are you're buying maybe a high deductible plan for that's going to cover you for the big stuff and the really scary stuff, and so you've got that coverage. And nobody expects you to be able to most people to be able to shell out for like a $40,000 knee surgery on no notice, right? I mean that's an enormous expense. But and so as long as you've got those kinds of bases covered with insurance, the question is like, well, what do you do with the annual primary care visit? I mean that should be something that you can cover out of pocket. And before anybody says, well, that could be $100, $200. Well, think of the money that you're saving by buying the deductible health insurance that is not going to be because that plan is going to be a lot less expensive. It's going to be thousands of dollars less expensive per year. And as long as you are, able to save that, put it away, put it in a health savings account again, that's one of the many, alternatives out there. Um, that's just sort of a better approach. It's a better mix of self-financing and use of insurance, I think. So the direct, literally direct pay just out of pocket like that for the regular stuff at the clinic level, and also even for like smaller procedures and imaging and that sort of thing as well. We've done some work on like the issue of allowing more direct pay healthcare facilities of various types open up. And I think we would see that. Again, this is sort of like something that we have to kind of predict would happen in a different world with different policy in place. I think we would get those options opening up because that's a perfectly fine business to be in. You can be providing imaging of various types and small, ambulatory surgeries and procedures. I mean, that's good business to be doing. But it's sort of a questionable area in today's context because everybody has the enormous comprehensive insurance.
Well, and because there are regulations in place that prevent, to a large extent, doctors and pharmacists and other healthcare providers, long-term care providers, you name it, from stepping in and creating innovative payment models. It's really just difficult to innovate because of the regulatory landscape that we're operating in now.
Just to summarize all of that, I mean, there's other kind of pushback that people give on shopping for healthcare, but I think two of the most common myths that I see about non-insurance ways of paying for healthcare is that, oh, so then it's like all like fee for service, right? Like, well, no, like it just means there's many different ways of paying for healthcare. It could be fee for service, like you're paying for a particular service, but it could also be a subscription-based model. There's many different ways that you can pay for healthcare other than in insurance. And the other myth of non-insurance based healthcare is that it can't be comprehensive. And that's not true either, right? Like, so direct primary care is a subscription-based model. I see no reason why like a business can combine that with a catastrophic healthcare plan and they sell that as a single product, right? And that would be comprehensive. Like it would cover both your routine healthcare and whatever falls outside of routine healthcare. It could be comprehensive. It just wouldn't all be paid through by insurance. So let's get into the kind of main pushback that people are giving, which is they push back both on this idea of shopping for healthcare practically and morally. So what's the practical kind of argument for why both patients can't shop for healthcare and doctors can't sell it.
Yeah. Well, one that you hear all the time is like, well, nobody's shopping for the best price on on physician services when they are like in an ambulance or when they're when
Having a
they're
heart attack.
yeah, they're actively having a heart attack, or they're
Yeah.
unconscious. I'm not going to be shopping around calling for best prices on something when I'm literally unconscious. Of course, I mean that's a straw man though. It's such a straw man. Um, that's, yeah, I mean, most of, Colleen mentioned this earlier, like most of care isn't delivered in that way. And I think it's wrong to sort of design the entire system around that
Yeah.
and then try to hope that it also applies to regular care when most of regular care isn't done in that panic
I
mode.
mean, I'm an emergency
Yeah.
medicine doctor. More than 90% of my patients could have gotten a same day appointment, gone to an urgent care, been seen in some other way if our system were set up differently.
And that's even your context, right? Like even yeah, right. Like if you had said, "Oh, everything that you see really is like unshoppable," then that would be fine, but that would still be just like one piece of the puzzle, right? And that lets out a lot of other care. So even if all but even you're testifying that that a large chunk of what you see could have been shopped, right?
In my own personal case, like I impaled something in my foot and considered going to the emergency room and thought better of it and figured out that well, I'll be there for like 6 to 12 hours and the bill's going to be way more. I'm just going to go to an urgent care center. And I was seen like in uh, less than an hour and like my copay was like $50 or something.
Yeah.
Right. And
I,
that was something that was urgent. It did need to be dealt with urgently, but you were able still to shop. It wasn't so life-threatening that you couldn't make a choice.
Yeah, and if it were something life-threatening, like I was hit by a bus or something, like that's what I would want my insurance to actually cover. But then,
Yeah.
like the tragedy today is that in those cases, patients still end up with bills that they have to pay on top of what their insurance already pays.
And there is one other thing I feel compelled to mention. So there are some studies out there that attempt to present, like introduce and test the idea of shopping, and many of them show that patients aren't particularly responsive to that. My problem with those studies, and so I mean, on the one hand, I'm glad that people are testing this out and looking at it and everything. But my gripe about a lot of those studies has always been that they're not allowing enough to change and enough to evolve in order to like get a good read on really what they're trying. So sometimes they'll test out an idea of like, well, if let's present patients with we'll have a randomized control trial and we'll present certain portion of patients with like a price list and then we'll see if they actually like put in some effort to go to the lower cost imaging center down the road versus the one that's right here in house or something like that and then they just that's the only change they make in that trial. And then, when kind of, I would say, unsurprisingly, most people don't really, put in much effort to do that. They then declare all of shopping like a dead end or something. And my point on those is that you're not really testing that well. You would have to, you'd want a system where like actual some of the reward gets shared with the patient in some way, and people get to know that and also like you need a few cultural changes in there where the physicians or the hospitals or whatever the clinic is that you're doing this in where they are now part of this and part of this messaging and you would want a few other things to evolve and if we were actually making policy changes to where this could evolve you would have some changes that would make the shopping part, I think, actually work. Yeah, so I'm not surprised that it doesn't work in some of these like limited kind of contrived tests, but I think it would work in like the real world if real policy were changed because more things would have to adapt.
Right. At the moment, doctors and clinics have no incentive to try to attract patients by, offering better facilities or making sure that they have good bedside manner or whatever it is. There's just no incentive to do that because it doesn't change their what they make. It doesn't change the payment structure. It doesn't make any difference for them. And similarly for patients, doesn't make any difference for their care, really. And they don't see any monetary reward for choosing to go to, maybe in the copays, sometimes there's a copay differential between an emergency department and a urgent care. But in general, there's not that significant of a monetary reward between choosing between one primary care doctor who saves you a little bit of money versus another. It's just not there.
This really points to the question of what does it mean to shop for healthcare, right? And if you have a very particular notion of what that means and you go looking for it and you can't find it, well, it could mean that like, well, it didn't work, but maybe the way that you're holding it isn't right. And on that topic, I think one kind of pushback that I see, which I'm much more sympathetic to, is that people will say, wait, so you want me to like to go around and like ask doctors and like different people all over the place for every particular thing that I need, that like I have to like do all that work? Well, I think you should be free to do that work, but I think that indeed would be like too time consuming for a lot of people. But that doesn't mean that it's not shoppable, right? Like we have all these other websites and businesses that essentially help you shop, right? For example, there are these websites that rate car insurance, right? Where you don't have to go by every car insurance and look at the policy and look at the cost and look all at all the things that it covers and doesn't cover. A business does that for you. So like the mere fact that yes, some information might be hard to integrate and to assess for patient doesn't mean that that would not be met in a market where you're actually free to shop for it. And then what you're shopping for are the different ratings and plans. And then the provider side will definitely want to make that information clearer to the people that are rating them, because if they don't, then like, well, then they're not on the website and you're not going to see them.
Mhm.
Yeah, and given time too, those places that you're talking about, like the clinics here and there and the different practices or hospitals, like they would all possibly change, right? And their culture about posting prices and sharing them and everything and advertising them, that would all evolve. Like you can't just kind of imagine like if somebody asked you to do that today, yeah, it would be hard today. I mean, there are some options, but it is hard. But you have to imagine what would it be like if that whole mindset on the producer side
Right.
also changed.
Like
Because
surgeons would start tracking their outcomes and reporting them. They would track their own infection rates and report it, or their success rates, or their like long-term pain after surgery rates, so that they could report their good outcomes. And then they would be driven to have those good outcomes so that they could report them, so that they could get more patients, because there'd be some consumer report for surgeons or something. I mean, I think, who knows how it would ultimately be, but any of these things would be possible given a system where that was what the value standard was, and where patients were making a choice and choosing based on that. And I think we tend to say, well, if we did this thing right now, it wouldn't work. And like, yeah, it wouldn't work today the way that we would like it to ultimately, but we have to keep in mind that our system today is based on a regulatory landscape that has incentivized very different things than the things that maybe actually really matter to us in healthcare.
So we definitely think that there's a practical case to be made that shopping for healthcare is possible. And someone might even concede that, but then argue that, well, maybe it's practically possible, but it's not morally desirable, right? Because we don't want patients, when they're facing a health-related issue, to be thinking about a cost, and we don't want doctors to have on their mind money, right? Like then there's like some kind of like moral concern that that's going to corrupt the kind of medical judgment and medical ethos that people expect. How should we think about that kind of pushback?
I see shopping for healthcare as a moral exercise. It's from the patient perspective, this is an exercise in your own rational self-interest. I mean, who doesn't have an interest in, I know some people aren't literally, feel like they have an interest in it, but everybody does have an interest in their own health and how they, live their lives. Productivity, I think, like this is productivity and independent judgment, I would say, both play a role here. Take the reins of your life a little bit. I think that would be a good thing. It's not to like get us sidetracked onto some other issue, but like for instance, I think that's one of my concerns about some ideas that I've heard lately about like eliminating pharma ads. Now, do I find pharma ads on television kind of annoying? Okay, fine, but like I actually don't want to take away that information flow, that the ability for people to like figure out and learn about something and pursue. That shouldn't be your sole source of information when you're deciding about like what to do with your healthcare. But like I think we want more information, more pursuit of this value, rather than less. From the patient side, those are some things that I would say. And I think it also applies to the producer side.
I think on the provider side, the producer side, the doctor side, our current system is so one size fits all that it has created a kind of culture of I'm checking the boxes, I'm doing the things that the insurance requires me to do, rather than a culture of let me consider the individual patient in front of me and what would be best for them. And I think that works something like 80% of the time because it turns out that most people with abdominal pain fit into the abdominal pain boxes that I've learned in medical school. But then there's the 20% of the time when it doesn't work. And doctors really aren't trained to deal with that. And we learn over the course of years, how to kind of figure that out. But it isn't, it's not kind of the moving force of medical care to be thinking in an individual kind of way. And I think it does a disservice to us as professionals to kind of not be thinking in that way, but and also to our patients over time. And it kind of builds in this way of thinking, like Ray said earlier, sort of thinking through the coding matrix, like kind of thinking through the way that we think about medicine is so keyed into whether things will be covered by the insurance, and rather than keyed into what's the best thing to do for my patient, that it really decreases the standard of health that everyone could be held to.
Yeah, so I mean, I would put it quite strongly as I want my doctor to think about cost and price and profit, right? Because in a system where they aren't being forced in their thinking through some coding matrix, if they're liberated from that, those things are signals for my values, right? And I want them to be tuned to my values. And so if anything, I want to see much more of that. And to the extent that people are concerned about doctors being motivated by profit and patients being concerned about costs, I see those as being warped by the current system of insurance paying for everything. And insurance is valuable for catastrophic things, but everywhere else, things like the pricing signal and the profit motive should be liberated to serve the needs of patients as signals for providers to meet our healthcare needs.
I also think it's important because, again, every single person has a different set of priorities. And so for you, your priority might be to save money because you don't have a lot of money. For someone else, that may not be their priority. And different structured ways of paying for healthcare, different options in terms of what health insurance you purchase, all of these things should be able to be kind of taken into account to kind of add together to what your healthcare is. And currently we just don't have that.
Yeah, and I think that if what people really want, not just personally, but if we're thinking about the future of healthcare and all of the science and promise that that has for personalized care when it comes to diagnostics and care that's like based on your specific genetics and individual health, we're going to need a lot more freeing up of doctors thinking and patients valuing very specific things, and those things are not going to be addressed if insurance is going to be paying for everything. And I think that's a good place to end, and I would like to thank our audience, and till next time.
Thanks, everyone.
To stay up to date, subscribe to our show from whatever podcast platform you are listening from. To support our show and the Center for Modern Health, you can make a tax-deductible donation at centerformodernhealth.org/support. Thank you for listening.